Welcome to the American Gastroenterological Association Clinical Practice Update on Managing Clostridioides difficile infection in adults. This expert review, authored by Fisher, Vaughn, Peary, and Kelly, provides evidence-based guidance with 14 best practice advice statements.
Clostridioides difficile infection, CDI, is a leading cause of healthcare-associated diarrhea, with about 365,200 cases annually in the United States. It poses clinical challenges, including high recurrence and severe cases with a 30 to 40% mortality rate. Management is evolving with new therapies as some older treatments are phased out.
Welcome to our overview of the 14 best practice advice statements. This American Gastroenterological Association Clinical Practice Update offers expert guidance across 4 key clinical domains: prevention and hygiene, diagnosis and severity, treatment, and recurrence prevention. Mechanical hand washing with soap and water is crucial for preventing Clostridioides difficile, as alcohol-based sanitizers are ineffective. Use Environmental Protection Agency-approved sporicidal agents on surfaces, ensuring a contact time of at least 10 minutes. Household transmission risk is low, and separate bathrooms aren't necessary with proper disinfection. Clostridioides difficile infection diagnosis requires new-onset diarrhea and supportive lab tests. Over-reliance on tests risks overdiagnosis due to high colonization rates. Use multi-step testing. Screen with glutamate dehydrogenase antigen or polymerase chain reaction, then confirm with toxin A/B enzyme immunoassay. If results are discordant but clinical suspicion is high, do not withhold treatment. Prompt severity classification is crucial in Clostridioides difficile infection diagnosis. Fulminant Clostridioides difficile infection, affecting 1.3% of cases, has a high mortality rate of 30.40%. Pseudomembranes are typically present in fulminant cases. Their absence suggests the need for alternative diagnosis evaluation. Fidaxomicin is the preferred first-line treatment for Clostridioides difficile infection, offering a narrower spectrum and reducing recurrence rates by 6.11% compared to vancomycin. Vancomycin is an acceptable alternative when fidaxomicin is impractical. Metronidazole should not be used for non-fulminant Clostridioides difficile infection due to higher recurrence rates and inferior outcomes. Avoid using bile acid binders like cholestyramine with vancomycin or fidaxomicin, as they reduce antibiotic effectiveness. Psyllium fiber aids stool consistency post-Clostridioides difficile infection recovery. Routine test of cure is unnecessary due to asymptomatic toxin shedding. Retest only if diarrhea persists with 3 or more watery stools daily for 2 days. First recurrence of Clostridioides difficile infection involves significant diarrhea within 8 weeks post-therapy. Use a different regimen than the initial course. If initial treatment was vancomycin, switch to fidaxomicin. For fidaxomicin, switch to vancomycin taper/pulse. Discuss microbiota restoration therapy, considering severity, hospitalization, and risk factors like age and immunocompromise. Fecal microbiota-based therapies, including Food and Drug Administration-approved VOWST and Rebiota, are effective for preventing Clostridioides difficile infection recurrence. These therapies are derived from screened donor stool. Conventional fecal microbiota transplantation is recommended after a second recurrence or earlier in severe cases. Immunocompromised patients may use these therapies unless severely compromised, where suppressive vancomycin is preferred. For patients unable to receive fecal microbiota therapies, long-term low-dose oral vancomycin is effective. It shows negligible systemic absorption, minimizing ototoxicity risk. Despite no vancomycin-resistant enterococci emergence, recurrent Clostridioides difficile infection risk remains high post-discontinuation. Long-term therapy may be necessary indefinitely. Bezlotoxumab is unavailable, and probiotics offer no benefit. In fulminant Clostridioides difficile infection, immediate coordination of a multidisciplinary team is crucial. Administer high-dose vancomycin orally or enterally, and add intravenous metronidazole for colonic exposure. If ileus is present, use rectal vancomycin. Consider fecal microbiota transplantation or colectomy if no improvement after 48 hours. Avoid empiric non-Clostridioides difficile infection antibiotics unless confirmed by infectious disease consultation. Fecal microbiota transplant significantly reduces mortality in severe or fulminant Clostridioides difficile infection, with a number needed to treat of 4. Multi-dose fecal microbiota transplant via lower endoscopy is recommended. Continue oral vancomycin post-fecal microbiota transplant. Note: Rebiota and Vowst are not approved for severe cases. Institutional barriers may require transfer to specialized centers. Oral vancomycin prophylaxis during systemic antibiotic use is not recommended due to insufficient evidence. Probiotics are ineffective for Clostridioides difficile infection prevention and not guideline supported. Instead, prioritize a diet rich in fruits, vegetables, and fiber to nurture microbial diversity. Avoid ultra-processed foods and opt for a healthy, high-fiber diet during Clostridioides difficile infection recovery. Proton pump inhibitors, PPIs, may slightly increase Clostridioides difficile infection risk by altering gastric acidity and the microbiome. Observational data suggest higher recurrence in proton pump inhibitor users, but a large randomized controlled trial found no significant Clostridioides difficile infection increase. For gastroesophageal reflux disease or ulcer prevention, proton pump inhibitor benefits outweigh risks. Antibiotic stewardship is crucial. Avoid unnecessary use and ensure clear indications, especially for those with a history of Clostridioides difficile infection. Welcome to our presentation on comprehensive Clostridioides difficile infection management. We'll explore the 14 American Gastroenterological Association best practice advice statements, offering a streamlined algorithm for prevention, treatment, and long-term recurrence strategies tailored to disease severity and patient risk. Fidaxomicin is the preferred first-line treatment due to its narrower spectrum, preserving gut flora and reducing recurrence. Severity classification is crucial. Severe cases have white blood cell count greater than 15,000 or creatinine greater than 1.5 times baseline. For recurrence prevention, consider microbiota restoration. Emphasize antibiotic stewardship, dietary fiber, and patient education to minimize reinfection.